I hope you can hear me, Mr. Kothari. Can you hear me?
Yes, I can. I can hear you, but your screen has just changed. I don't know what's happened.
Okay, let's let's start again. This is BreastCare Insights. This is the third episode of the webinar series that we discuss with experts from all over the world about advancements of breast surgery and breast cancer management, as well as get an insight of how we can utilize this in different parts of the world, especially in countries like Sri Lanka, India, Nepal, and other countries that might have differences in practice as well as facilities available. So today we have a special guest. As you can see, it's Mr. Ashutosh Kothari, a renowned orthoplastic breast surgeon who has done a great deal of work over past 2 decades and has been a pivotal character in advancing breast cancer and breast cancer management as well as breast cancer surgery, especially in the UK. And then his reach has gone beyond that proportions as well. So he has been the clinical lead of Guy's and St. Thomas's NHS Foundation Trust for a period of time, and he's still working as an oncoplastic breast surgeon. A senior lecturer at the King's College Faculty of Medicine, London, UK, and also director of breast cancer at the Reliance Foundation Hospital in Mumbai. He has had many honors and positions held, being a director of European Society of Surgical Oncology, being a director of European Board of Breast Examinations in Paris. The list continues. So today we thought of discussing about the importance and nuances in the management and identifying margins in cancer surgery, which is what is enough and how do we confirm that it is, and what is the evidence behind this. I think we'll have a good discussion at the end of the presentation. I would like to invite our listeners to enter their questions in the chat function, or those who are joining us from YouTube, that is breastcareinsights.com. At YouTube, you can send your questions through the chat function as well. So let me invite Mr. Kothari to take over.
So I'm just going to share my slides. So I need to go back one. Right. Can you see them now?
Yes, all clear.
So thank you, Dr. Pathirana, for having me and for the kind introduction. So like you said, we're going to speak about margins. So how marginal we are on margins. Let's have a look. So these are my disclosures, and nothing I say today will be conflicting with the topic at hand. Just give me 1 second. I need to minimize that. Perfect. And we are undeniably in an area of conservatism. Conservatism means do as much as possible to the disease and do as little as possible to the patients, because we now know that biology is what dictates outcomes and the sword is not mightier than the biology. And we have emerging evidence coming from various articles that shows that breast cancer survival is actually improved from breast conserving surgery. I don't believe this as yet because it's not randomized data. There is a bias in this study, primarily that patients who undergo a mastectomy, although this is adjusted for those kind of cohorts, there is an inherent bias in the study. However, what is undeniable is that breast conservation rates are going up because of our better understanding of tumor biology, neoadjuvant therapy, shrinking down tumors, also new generation systemic therapies allowing for shrinking of tumors down to 65%, virtually with PathCR, and then you've got tailored treatment plans in oncoplastic breast surgery. You also have extreme oncoplastic breast surgery. You've got chest wall perforator flaps. You've got rotation flaps. You've got displacement and replacement, everything going on together. So we have increased our palette of breast conservation, which is here to stay. There are certain units like Michael Nance unit in Austria that boasts of 98% breast conservation. Of course, there is a screening population there, so we don't have that kind of luck in the subcontinent where we are. Like you said, Nepal, India, Sri Lanka, and the surrounding countries probably get T2 and above disease and not T1. So we need to look at what we do in our scenario. The conflict with breast conserving surgery is always very simple. You have to balance what is aesthetically viable with what is oncologically safe. And you end up with margin compromises because you're trying to get a good aesthetic outcome without using proper techniques, and you skimp on how much tissue you need to remove. So that balance needs to be struck. And margins matter because if you leave positive margins behind, then as we all know from these two meta-analyses, which was published in 2002 and then again in 2014, that you have a higher loco-regional relapse. And the risk is about 2.4 times if you believe Husami, and even higher if you believe the Singletary from the US. But we know that loco-regional relapse is slightly higher with breast conserving compared to mastectomies. However, with radiation, it is brought down, and it's 5% over 15 years, which is acceptable, to 3 to 6% in the next study, again over 15 years, which is very, very acceptable. When we look at an optimal margin of width, we look at what is a good negative margin. Does a negative margin mean that the rest of the breast has no cancer in it and there is no tumor in the unresected breast? What we believe that when we achieve a negative margin, whatever residual tumor burden is in the breast, which is left behind in the breast, is dealt with effectively by either radiotherapy, systemic disease, systemic treatment, or inherently that biology is so weak and so well behaved that it doesn't make a long-term outcome while you're being treated for the disease that you have, because that disease is also treating that cancer. So again, biology is king. The widest margin you can get is a mastectomy. So the widest wide local excision is a mastectomy. But we know that even if you do a mastectomy, you don't eliminate the risk of a local regional relapse. And how does that work then? Because there's no more breast tissue left. You can never get a zero-sum game when it comes to local regional relapse. I think we need to understand that if it's 1 to 2% with a mastectomy, or 5 to 6%, or even 10% in 15 years with certain biologies of breast cancer, you can never get a zero-sum game. And we know that tumor biology, radiation therapy, systemic therapy play an important role in controlling local regional relapse as well as systemic relapses. And coming down to local regional relapse, why does it matter? Because this old meta-analysis, and I'm saying old because it's 2011, showed that for every local regional relapse that you prevented 10 years, you save one life at 15 years. So I'll just repeat that so you understand. So every cancer that you prevent from recurring locally in the breast or the axilla at 10 years will pay you back dividends in 15 years, because 1 in 4 of them will die of the disease at 15 years. So if you have 4 local relapse, one of those patients will die. Now, there is again a debate going on whether this is true local relapse. So those patients that relapse locally also harbor systemic disease at the time of the disease. ctDNA does the same rule. So let's say if you do a ctDNA for all the patients who have a local regional relapse, that one person who dies, people will argue, have circulating tumor cells. So it's not the same on a pure local regional relapse. Now, I call this the margin index because we've seen the margin game evolve from when I was training back in 1997 at the Tata, 1 centimeter, and then the goalposts kept changing. But if we go even further back to 1970, when we look at the first trial, the BO6, NSABP BO6 study, the definition for that breast conserving tumor study was no ink on tumor. So it's worth remembering where we are. We are in 1970s, and this is a seminal trial, NSABP BO6, And the definition of a negative margin is no ink on tumor or no tumor on ink. Then in 2010, Hosami's meta-analysis again said a greater radial width of the negative margin had borderline significance on improving local regional relapse. So for 1 millimeter compared to 2 millimeters compared to 5 millimeters, it makes no difference because this is adjusted when patients receive a boost or and endocrine therapy. Then in 2014, you had the big consensus guidelines which came out of America when ASCO, SSO, ASTRO all sat together and said, let's look at what is a clear margin. And they went back to 1970 and said, okay, if there is no tumor cells on the inked edge, i.e. there's no ink on tumor, then that is a clear margin for invasive cancer. And for DCIS, they said it's 2 millimeters. And if you have a component of invasion and DCIS, then the invasive margin applies, which is 1 millimeter rather than 2 millimeters. Okay. So, or no ink on tumor even. So in 2014, the guidelines were no ink on tumor for invasive, DCIS 2 millimeters, and no ink on tumor or 1 millimeter for if you've got invasive and DCIS. Now, most of Europe has agreed with no ink on tumor or no ink on tumor guidelines. St. Gallen's consensus debated this twice, 2015, 2017. Finally, in 2017, it said, yes, we will adopt no ink on tumor. And then, of course, in the UK, we have to be slightly different. We've left Europe, so we can't agree with Europe. In 2015, the ABS, the Association of Breast Surgeons of UK, said 1 millimeter for all comers, regardless whether it's DCIS or invasive. You need 1 millimeter. Thankfully, guys, in 2015, when I was the clinical lead, we had 2 millimeters for DCIS and 1 millimeter for invasive. And we've always maintained that. We've not changed these guidelines, even though we've gone back to this new consensus. Then in 2022, Nigel Bundred and his son published data which said, compare no tumor in ink to 2 millimeters. So it's worth remembering that this paper, they compared no tumor in ink to 2 millimeters and looked at all the data. And they said, if you have 2 millimeters, you have lesser chance of a local regional relapse compared to no tumor in ink. Fine, I accept that. But it's worth reading the paper because the outcome or the conclusion of this paper said, so because 2 millimeters is better than no tumor in ink, we recommend 1 millimeter. So I don't know which side of the bed he woke up in the morning and decided that 1 millimeter is okay, but that's the recommendation that came from that. And one step further, in 2024, Linda Wild and Karina Cox from the UK sat together and went through what they called the Sheffield Centre of Health and Related Research, or the SHAR guidelines. And ABS published these guidelines, which said, we support 1 millimeter after Nigel Bundred's paper. And then we support between 0 and 1 millimeter. If the margin is less than 1 millimeter and it's focal, then have a discussion with the patient and decide what's the best way forward. Now, I feel that this is absolutely ridiculous. When an MDT cannot come up with a recommendation, to have a conversation with the patient and say, well, we feel that there's very marginal benefit, but if you want, we'll do a re-excision, is bizarre. So why did America move the goalposts? Because they had a very, very high, they had nearly 50% re-excision rate at the time in 2014 when these guidelines were published. And depending on which center you're looking at, you had 35%, 40%, 45%, and some went up to 50%. So there was a lot of re-excisions going on. Of course, it's good for the surgeon because they were making money. America is an economically driven society, but bad for the patients. So by changing it from 2 millimeters to no ink or no tumor on ink, you had a reduction of the re-excision rates down to close to about 14%. So you had a 50% reduction in the re-excision rates as a consequence of moving the goalposts. Of course, we now are seeing the payback of that. We are not seeing, although there may be a slightly high local regional relapse, there isn't any compromise in overall survival. And that's worth remembering, because although overall survival matters to clinicians, I think if you ask a patient what matters more to them, they will favor a no local regional relapse or no relapse at all. Now, even in the states when the reduction went down by 50%, did it go across the board 50%? And the answer is no. The big academic centers saw a reduction because they adopted the guidelines, but surgeons will be surgeons. And if you look at the population-based, rather than institutional re-excision rates, the population-based re-excision rates did not budge. It means that certain centers adopted the guidelines, certain centers said, no, I still want to have the 1 to 2 millimeter guideline, which I've been used to, like us. We said 2 millimeters and we stuck to that. And I still think in due course, Providence will show who's right and who's wrong. But we are 1 millimeter for invasive and 2 millimeters for DCIS. So even in the States, there is a lot of discrepancy. Even in Europe, like I said, there is discrepancy because we in the UK don't believe this to be true. And surgeons will be surgeons, they don't listen. So the quest for margins continues. Now, if you understand locoregional relapse, you have to think about why does a patient get a locoregional relapse? Is it purely because you've left tumor behind? And I'll show you in the future slide that can't be accurate. So what else is it? So let's look at the various things that can influence locoregional relapse. Treatment, of course it does. Whether you're given the right dose of radiation, you're given a boost when it's due, whether you've given partial breast radiotherapy, you've given whole breast radiotherapy, whether you've given accelerated radiotherapy, everything that you give has to be right for the fit. It's not that because fast forward came, I'm going to give everyone fast forward. Of course, those patients that are not suitable for fast forward will have a higher locoregional relapse. The same thing goes for things like tumor biology. Triple negative breast cancers, HER2 positive breast cancers are not going to have the same locoregional relapse rate or profile as a luminal A. And then, of course, you've got lymphovascular invasion, younger patients versus the older patients, tumor size, T1 versus T3, you're not going to get the same locoregional relapse, and focality. Multifocality versus a single focus may not have the same locoregional relapse. So you've got a multimodality causation for local relapse. So it's not just the extent of surgery that's going to detect or dictate locoregional relapse. Now, this is data that came out of two papers in 2011, as early as 2011, and again in 2019, when we looked at does biology make a difference on locoregional relapse? And if you look at there, yes, luminal A, luminal B, luminals, then you look at the HER2 positives, which is the blue line, and then the blue line is the triple negatives and the gray line is the HER2 positives. And you can see that for triple negative breast cancer, there's 10% at 7 years compared to, remember what I told you earlier, was less than 5% at 15 years. And again, the same thing happens if you look at the biology, which is aggressive biology, HER2 and triple negatives, 8% at 10 years compared to 2% for luminal A. So we know that bad biology is a bad marker for rest of disease. Now coming back to, have I left any cancer behind? So this is a beautiful study which was done as early as 1985, and then a very good friend and colleague of mine, Jayant Vaidya, repeated the study in the Tata in the early 1990s, when they looked at patients who had a lumpectomy, if they had a mastectomy. So these patients who had a mastectomy, they did a lumpectomy and got clear margins in them. Then they went on to the mastectomy, and they looked at the mastectomy specimen in the lab. What they found, so these patients had already decided they want to have a mastectomy. They didn't do the mastectomy for the sake of the study. So you need to understand that they did a lumpectomy and then had a mastectomy. They looked at what happens beyond the resection area. So in the rest of the breast. And if you look at this, 2 centimeters away from the cancer cavity, right? So let's say you had a margin of 2 centimeters clear. There's a 47% chance you would have new cancer or newer cancer foci in the remaining breast. If you went 3 centimeters, it's 33%. 4 centimeters is 20%, and 5 centimeter margin is still 10%. So again, no zero-sum game is possible unless you do a mastectomy. And I already told you, even if you do a mastectomy, the local regional relapse rate is still 1 to 2%. So even the widest wide local excision doesn't make or doesn't ensure that there's no residual breast tissue or there's no residual tumor cells. Radiation therapy, we know, reduces local regional relapse by about 50%. The absolute risk reduction, of course, is tumor biology and sensitivity to radiation. Endocrine therapy, we know, NSABP showed a 4% reduction local regional relapse with tamoxifen compared to 14% with placebo. NSABP showed with chemo 2.6% compared to 13% of without chemo, and this is methotrexate and 5-FU. I mean, those drugs nobody even uses now in breast cancer. But even that caused a 4-fold reduction, right? And Herceptin versus no Herceptin, 1% versus 10%. So 9-fold reduction. Great. This is another data that showed you a collection or a systematic review of 53 randomized controlled trials, where there's almost close to 87,000 patients between 1990 and 2011. Again, the systemic therapy during this period wasn't as good as what we're giving them now. There was no targeted therapy, there was no dual blockade, there was no pembrolizumab, there was no CDK4/6 inhibitors. So a lot has changed. There was no ovarian function suppression and letrozole and exemestane. So all these things have changed since 2011. But if you look at the data when this was actually, when none of these things that I mentioned were there, you look at the proportion of local relapse was decreased from 30 to 15% with systemic treatment. And it is the biggest decrease is seen with chemotherapy, but you also see a decrease, which is the green line, with tamoxifen. Again, with purely tamoxifen. So better systemic therapies have definitely played a very, very good role in the reduction of local relapse. So it's not just the surgery, it's also the treatment that goes with it over and above radiation therapy. Impact of neoadjuvant chemotherapy on local relapse. These are 3 studies again, big studies. When you compare different types of treatments, TDM1 compared to trastuzumab, capecitabine compared to control, and then you got olaparib. All these also reduce local regional relapse. Not only that, they also give us, according to the German press group study, an 8% overall survival benefit at 8% at 8 years with TDM1, presented at San Antonio in 2023, and the FINEX, which showed that capecitabine, or capecitabine even, had a 4% overall survival. So these are absolute benefits at 15 years. So not only do they relapse, they prevent local regional relapse, they also prevent systemic relapse. So as treatment gets better, these patients are going to live longer with fewer events like local regional relapse. So in summary, we are seeing in 2025, 2026, LR is decreasing because we are having more patients, even in countries like India, because I have been, doing a bit of practice in India over the last year. Patients are coming forward for executive health checkups, for breast screening. They are coming to one-stop breast clinics. So, like the West, we are going to detect smaller screen-detected cancers. We have lesser residual disease because the surgical planning is more accurate. We do tend to do more MRI scans. We are more precise, targeted excisions, needle localizations, non-wire guided excisions, using seeds, ultrasound, use of oncoplastic conservation techniques allow us to do wider excisions, bigger margins, and cosmetically viable. Standardized pathology and immunohistochemistry. So we know that we're supposed to look for margin width, and that is now a part of didactic pathology reporting. Good and judicious use of both radiotherapy and systemic treatment. So coming back to the question, is in today's world, does the rule of 1 in 4, the one life you save or the one local regional relapse you prevent at 10 years, hold good for preventing one death at 15 years? And I think this is no longer true. I don't think that this rule, which was there in the EBCTG meta-analysis, is true in 2026 because of the various things that I showed you, that not only do the drugs reduce local regional relapse, they also improve overall survival. So I believe that certain biologies like triple negatives, when they occur locally, they are aggressive biology tumors. And that 1 in 4 is already systemically seeded disease and refractory to treatment. So those patients are going to do poorly. And it's biology, and again, not the surgery or the margin. So with a better understanding of the influence of molecular and genomic profiling, we know tumors behave more aggressively. We will introduce targeted therapies. And the width then is basically semantics, because if a tumor responds really well and becomes from node negative to node positive, you know these patients are going to do well. But at the end of the systemic treatment, let's say they don't do well, you know that whether this treatment is given in the adjuvant setting or the neoadjuvant setting, those patients have done badly anyway. So they would be that 1 in 4. We also know that if you all the breast cancer is removed, there's still breast cancer which is multifocal and more foci in the breast. Only about 1/3 of breast cancers are truly unifocal cancers. That means in the focus of breast, if you do a mastectomy and a lumpectomy at the same time in the same patient, in the same breast, you'll find that only 1/3, just 25% have unifocal cancer, 75% have tumors elsewhere in the breast. Breast MRI finds cancers. Of course it does. We use more and more MRI scans, and I think that's an abuse of an MRI scan, because if you use an MRI scan, you will find more foci of disease, which I told you already exist. Remember all the trials that have been done for breast conserving surgery, which are seminal trials on which we base breast conserving surgery as we know today. Not one patient had an MRI scan. We know if you do an MRI scan, 18% of patients will end up with a mastectomy, because you'll pick up these additional cancers which would have done no harm to the patient, because we have randomized data and we have got a review of all this data and more than 6 trials that have been published where it didn't make a jot of a difference. So histology is going to find more. So let's say you do an MRI scan and you find 18% more. We already told you in the previous line, if you do a mastectomy, you'll find 75% more cancers. But does that make a difference to overall survival and to local regional labs? No. So we're coming back to margin assessment. So I would urge all of you to go to the lab and sit down with your pathologist and see how perfect or imperfect science is margin assessment, right? It's more by feel. So when you give them the specimen, they feel the specimen and tell you, yeah, the margins seem clear, but this margin seems close, so we're going to section it. The first thing when we do margin assessment is you have to agree with your pathologist. What are you going to mark? The orientation is very, very clear, because when a re-excision comes, you need to know which margin you're going to re-excise. Otherwise, it's like you might not put any markers at all, because it's not going to give you. And these are the various things that have been used across the world. And the question is not only marking these, is to agree who's going to do the re-excision. So if you do a complex oncoplastic breast surgery procedure, and you've done, let's say, a superior medial pedicle reduction, and you've rotated the pedicle up, and the nipple margin comes positive, then shaving the nipple margin in the same area is not going to give you that margin. The margin is at 12 o'clock. So you need to shave at 12 o'clock. So the surgeon who does the surgery needs to understand which margin he's going to excise. Again, what margins are we talking about when we talk about margins? So if you do the classical wide excision, which is down from the almost subcutaneous tissue to the pectoral fascia, unless the pectoralis fascia is directly involved by tumor, I don't excise it, and you don't need to excise it, because even if you look at the sarcoma principles, you just remove one compartment and you don't remove the compartment next to it. So there's no advantage of taking a cuff muscle. But anyway, we're talking about radial margins. So radial margins are the anterior, lateral, medial, and inferior. Oh, sorry, superior, inferior, medial, lateral. Those are the radial margins. Then you've got the anterior margin, which is skin, and posterior margin, which is fascia. If you get DCIs in the posterior margin, you know that you've got a fascia, which is a firm layer. There's nothing more to excise. Even if you get invasive cancer at the fascia, as long as the fascia is not infiltrated and the tumor shaved off beautifully off it, you don't need to take it. So skin is not the anterior margin of the tumor. It's the breast parenchyma is the anterior margin, or the fat, unless there's dermal infiltration, which you will know clinically before you did the operation, unless you've never assessed the patient except on table. Then there is the pancake phenomenon. In the breast, the tissue is supported by the Cooper's ligaments, by connective tissue, elastin, collagen, what have you. You take that tissue out and you put it on the table. And what happens, a tissue which is cylindrical, because you've taken a perfect cylinder down from skin down to muscle, you put it next to it and it becomes like a pancake. It just drops and flops because it's fat. Remember, most of our patients are elderly population. Breast cancer happens 55 and above. In India, 65 and above in the West, right? So these patients are going to have largely fatty breasts, so it's going to flop, it's going to flatten. So what happens when it flattens? The anterior and the posterior margins come closer to the tumor. So let's say you've taken a 6 millimeter anterior margin and a 6 millimeter posterior margin. Suddenly everything sits on the posterior margins. The posterior margin becomes 1 millimeter. And if your margin excision rate is 2 millimeters, you're stuffed. So there's the pancake phenomenon that happens, and we need to be aware of this. And the other problems are technical. So when you're inking it, surface ink can track along little cracks or fissures along the tissue or tears that you've got, because fat, while handling the fat, a bit of it shears off. Sectioning is carried out perpendicular to the ink as shave margins. The advantage of shave is you have a greater area of sample. Disadvantage of shave is more margin positivity, because the more you sample, the more you find. even if you look at the whole specimen in its entirety, the pathologists have looked less than 1% or 2% max of the circumference of the tumor in 360 degrees to give you a margin assessment. So we base our whole margin debate on a 2% sample of that tumor. And this is worth remembering. So again, if you look at the margins, whether it's sectioned straight or whether it's sectioned slightly tangentially, if it's perpendicular, yes, you get a nice margin, but it goes slightly tangential, that 2 millimeters above can become 1 millimeter below, and even below can become no inguinal tumor or have a positive margin. So how accurately is that section? Again, go and see a pathologist doing it. It's literally a knife and going chop, chop, chop. There's no science to it. So these are little things which are operator dependent. Now, optimal margins, of course, we want them negative, but in pursuit of the optimal margin, what we end up doing is repeat surgeries and more re-excisions after breast conserving surgery, right? And if you look at all the data in the world, your re-excision margins were about 14%. Okay, overall positive margins out of these were 12%. So if you excise or do a re-excision of all the margins that you think are positive, 50% of these will have no residual disease. So that was a needless exercise. Either you're excising the wrong bit or that has no tumor on it. But either ways, you've accepted it and the patient's gone for radiation. Do these patients have a high local relapse? No, they don't. And sorry, I should have said that. The American Society of Breast Surgeons, this is very worth remembering for all of you guys and noting that no other ABS, ABSI, or any of the societies, ESO, ESMO even, have set a guideline which says that this is a benchmark, guys. You need to target below this. The American Society of Breast Surgeons has said that a good center should have a 10% or less re-excision rate, right? And remember, this is without frozen section. So all these centers and studies that we're talking about is without frozen section. Frozen section is very, very widely used in India and Sri Lanka and countries around. But these countries don't use frozen section because they don't believe that a frozen section is a good use of a valuable resource, and pathology is scarce. So in the NHS where I work, you can't get frozen section even if you pay for it. So what does the burden of re-excision actually mean to the patient? It means worst cosmesis possibly, second surgery, risk of ending up with a mastectomy, more morbidity, more delayed healing, more delayed to adjuvant treatment, and of course, the cost or the socioeconomic cost of not being able to go back to your work. Because a lot of people in the West, especially, or even now in India, the nuclear families or single mothers need to work to feed the kids. I can't go back to work, and the more surgeries I have, the longer it takes for me to recover and get my adjuvant treatments. That delays my treatment and increases my mobility. I can't work. And then, of course, you've got the cost of admission, theatre time, especially in NHS and a public sector space. You don't just have that liberty. And of course, the imprecision, like I said, of the repeat surgery. You think you know where the margin is. The pathologist thinks he's told you accurately where it is. But it is all a guessing game. So we don't know whether you've actually sampled the right area and it's negative, or you've sampled the wrong area and it's negative. In the UK, if you look, and this is data from 2005 to 2008, right? The average re-excision rate was 20%. This is 2005 to 2008. Then we moved the goalposts. And even ABS said 1 millimeter will do. The Nigel Bundle said 2 millimeters. Then we went back to 1 millimeter, right? In the world, these are the, in the US, these are the re-excision rates, as you can see. It ranges from anywhere between 24% to the lowest being 20% or 18%. And it depends on, again, which part of America you stay. But if you look at the New York State area, it's about 24, 26%. The best rates in the US are approximately 4%. So if you look at the very, very good centers. Now, like I said, the margins that matter are 4, medial, lateral, superior, inferior. Fat falls off the tumor, which is true at the time of processing, at the time of handling. So how positive is positive? Is it focally positive, which 2 millimeters or less, or is it more than 2 millimeters? Is it focal in one area or is it multifocal? and not all margins carry an equal risk. Radial margins is breast tissue, unless you do a mastectomy, in which case there is skin and there's the superficial fascia of the corpus mamma. The anterior margin and the posterior margin, again, has fascial barriers, corpus mamma, pectoral fascia. Radial margins don't. That's why unless you have really grossly involved skin or muscle, you don't go back and excise anterior and posterior margins, but you excise radial margins. And this is data that shows that if you re-excise the anterior margin, you will do 49 re-excisions to find 1 or 2 anterior margins that may be involved. So people don't prefer to excise anterior margin unless they know that they haven't excised from skin down to fascia. Because we are looking at knowing tumor, people believe there's no point of sticking to the fascia if the tumor is deep, because we have ultrasound. The radiologists tell you the tumor is 4 centimeters below or 2 centimeters below the skin, so you don't need to go from fascia. We are in an era of conservatism. So I totally get it. So if the anterior margin and posterior margin is not completely excised and you get it positive, please go back. But if you've gone from skin to fascia, you don't need to go back. Again, with neoadjuvant chemotherapy, what happens with margins? If you have neoadjuvant chemotherapy, you are more likely to get a positive margin than with a primary upfront surgery. So performing BCS after NSAT to reach tumor-free margins is not accomplished in 1 out of 4 patients. So 25% of patients with neoadjuvant chemotherapy will have a re-excision, again, without frozen section. And the other option is to take out the original footprint, which defeats the purpose of doing neoadjuvant chemotherapy, because you sometimes do neoadjuvant chemotherapy to facilitate breast conservation. So what is it that we excise post neoadjuvant therapy? Do we excise the footprint, the original footprint, or do we excise what's left, the clip area or the clipectomies? We would, depending on the imaging that you use, MRI scans, mammograms, ultrasound scans, you'll use the same one to assess response. And if it shows a very, very good response, then you'll of course de-escalate surgery. But if it shows a bad response, then it's the original footprint. If it's a mastectomy, it's a mastectomy. Now, I've just highlighted this to show you that if you've got a Swiss cheese or a cottage cheese like response, you may be able to sample the clip and get negative margins. Those are not truly negative margins, and this is worse than upfront surgery, because remember I said in upfront surgery, not only radiation, but chemotherapy and endocrine treatment will also play a part. So this was a triple negative cancer. You've shot your chemotherapy bow, so that 30% reduction that you get in margins is gone, and you're not going to get it anymore. So getting your margins accurate in this actually matters much more than getting margins accurate in the upfront surgery, because your triple negative breast cancers will have a 30% reduction with the administration of purely chemotherapy. And if you add pembrolizumab on top, I'm sure that 30% will go up to like 40 to 50%. So what are the guidelines for re-excision when you're downstaging using neoadjuvant chemotherapy? If you get along the specimen with negative margins, nests of cells which are lying scattered across the tumor, then even the American College of Radiologists and the College of Surgeons and SSO, all three of them agree that you should go back and re-excise margins, because you've probably got a Swiss cheese-like appearance. So remember, when you have neoadjuvant chemotherapy, if you've got complete patsy, that's fine. If you've got a single focus of tumor in the middle and the margins are clear, that's fine. But you've got nests of cells throughout the specimen, then you should go back and take more margins, because again, this shouldn't be your hunch. It should be an MDT discussion. There should be some correlation with what we're seeing on the imaging, whether the imaging was able to tell you beforehand of what you're seeing on pathology now, and how much you can believe and depend on that imaging. What about mastectomies? So do margins matter with mastectomies? And you think, what is wrong with this guy? There's a 1% reduction and 1%, 2% recurrence rate with mastectomies. But I would argue that if a patient has opted to have a mastectomy, she's opted to have it because she wants to have a very, very low risk of local regional relapse. So having a positive margins in mastectomy actually defeats the purpose. You're doing her a disservice by leaving tissue behind when you have a mastectomy to see whether you can. So failure to achieve clear margins for mastectomy increases risk of local relapse. And this is across studies. So we do see that after skin sparing mastectomies, positive margins are associated with a 3.4 times higher risk of local relapse when compared to negative margins. So if you look at a 2% risk of local relapse at 10 years with a mastectomy, a 4 times or 3.5 times higher is of 7%, which is coming to breast conserving surgery. So why would you do a mastectomy in the first place? So can we prevent getting negative margins? What can we do as surgeons to prevent getting negative margins is the next question. Oncoplastic breast conserving surgery, yes, it does reduce re-excision rates because we can take more, but not all the studies show this. There are interoperative techniques like margin shaves, Saxitron, margin marking, like I told you, research devices like the iKnife, margin probes, all these things are available. More imaging, does it help? And if I ask you today that if we do a MRI scan versus a mammogram and ultrasound scan, does it help prevent getting negative margins? Your answer would be, I'm sure, a resounding yes. But the data says a resounding and bigger no. So if you look at the COMES trial and the MONE trial, both evaluating the effect of preoperative MRIs on margin positivity, it did not show any association at all. However, in the MONE trial, they did find a non-significant yet a trend towards a higher re-excision rate. So read this properly and hear this properly. In the MONE trial, patients that had an MRI scan, in fact, had a trend to a higher re-excision rate. It didn't reach statistical significance, but it's worth mulling over the point that if you had an MRI scan, you're more likely to have a re-excision. So it defeats the person. That's why following these trials, the American guidelines, choosing wisely guidelines said, you don't need an MRI scan routinely in preoperative imaging. Yes, dense breasts, yes, lobulars, but routinely because I want to plan my surgery, so I'm going to oncoplastic surgery, so I'm going to do an MRI scan, is not supported by any guidelines and not supported by common sense either, because you might plan a very, very good oncoplastic breast surgery with a chest wall perforator flap, but you do an MRI scan, you find more disease, she ends up with a mastectomy. If you hadn't done the MRI scan, you would end up with a nice chest wall perforator flap, breast conserving surgery, and would make no difference to local relapse and overall survival, because we've already discussed why in the preceding slides. Then, of course, there is a randomized trial to say, if we take shave margins, does that help? So this was a study which randomized 235 patients, so DCIS to stage 3, and the rate of positive margins after mastectomy before randomization. So partial mastectomy, sorry. So lumpectomy was done. Then the patient was randomized to take shaves, not to take shaves. Shaves meaning I will take 4 cavity shaves. I'll take superior, inferior, medial, and lateral routinely as part of this randomized trial. So some will just have a lumpectomy, some will have a lumpectomy shave, but that is not decided before the operation. It's decided on the table. After the lumpectomy, the patients have this, and the positive margin rates was similar in the shave group and the no shave group. Okay, so it's worth remembering. Although after randomization, so when we did the lumpectomy and we looked at margins in both the arms, because at that point we hadn't decided to take shaves, it was the same. So in one it was 36%, one was 34%. However, when we took shaves in that group that was randomized to shave, that then went down by 50%. So taking shaves routinely means you will reduce your margin positivity rate. Now, if you think about this, it means that you skimped in the first time and you didn't assess the tumor properly, because by taking 2 millimeters more, which you could have done at the initial surgery, you would have saved the shave. But why did you do that? Or why would surgeons do that? If there is more tissue to take, I'll take more tissue. So again, this balance between aesthetics and risk of recurrence is a problem. And that's where we err on the side of, let me take less and see whether I get away with it. And then, of course, you have the SHAVE 1 and the SHAVE 2 studies, which said oncoplastic breast surgery, you would think, I have so much more tissue to take. So if I do a shave for oncoplastic breast surgery, it should make no difference. But again, if you see, there was a risk reduction down to 6% versus 33% when you did shave even following oncoplastic breast surgery, right? And then, of course, you got frozen section. So there is no argument here, having now come to India and used frozen section, that our concordance with final histopathology between frozen section and final histopathology is almost 98 to 99%. So 1 to 2% of patients having surgery in poor little India will have a re-excision of margins. That too will be focally positive disease, if at all. And that is repeatable, which as we will come to. So we know that at best, 5.9% of patients with frozen section will go on to have, and this is data which is not from here, but let's go with it. It's international data, it's systematic review and a meta-analysis. So let's have a look at it. 5.9% best, right? Because remember, UK was 20%, America was 24%, 5.9% frozen section. Great. It's a very, very good way, cheap way, without taking a shave, of knowing what your margins are. Now, if you were doing a shave and did a frozen section of the shave, your margin re-excision rate would be 2%. And then, of course, you've got imprint cytology. So if you look at the final re-excision rates after primary breast conserving surgery, so 35% for paraffin section, 11% for imprint cytology, and 10% for frozen section. So both imprint cytology and frozen section have a very, very good correlation with the final outcome, much better than paraffin. What is imprint cytology? For those who don't know, you take the margin, because cancer cells are discohesive to begin with. When you put it on a slide, the cancer cells will shed off and stick to the slide, and therefore you will see them. So that's imprint cytology. Is done for cores very often. I was the first person in the UK to introduce this for our one-stop clinic when we did an imprint cytology of the core, and we were able to confidently tell the patients with cancer that they had cancer and tell the benign patients that you're most likely to be fine. Of course, there's intraoperative ultrasound scan. So ultrasound is very, very easily available. You use it for ports, you use it for all sorts of things, to find wires, to find clips. So you can save a lot of money. It's very easy to use. You just have to sit and play around with one of these devices. It's available inside the theater, so there's no scheduling problems. It's a one-time cost of procurement of the machine, which can be recovered from the patients or from the healthcare system. Of course, it has a learning curve, and you would go with a mentor when you started off with, but it gives you a very, very good real-time assessment of the margin of the tumor, where it is, and the margins when you have them. So lower positive margins compared to wire-guided excision and to radio localization of occult lesions. 3.5% or 7% on ultrasound scan, 21% on wire-guided, and 25% on roll. And I believe that the Tata Memorial Hospital in India is going to start roll. So this is some data that they should look at when they're considering this as well. So what is roll for the uninitiated? They introduce a seed or a small amount of radioactive isotope is injected in the center of the tumor, and then they base their excision on that. Limitations to ultrasound, of course, are the tumor has to be visible on ultrasound. Most of them are. There is poor sensitivity to microcalcifications, of course, in TCIS, but now there are a few ultrasound scan machines, especially from GE, and there are systems from Canon called MicroPure, which claim to pick up DCIS with the same sensitivity, and signal to noise ratio is elevated with a higher skill activity level, and they will pick up the DCIS. So these are things that are evolving, and a simple ultrasound can give you a 3.7% re-excision rate, which I think is brilliant, almost matching up to frozen section. So I think if we wanted one thing that works, an ultrasound scan is definitely something we should look at. The US is the only country that mandates for non-palpable lesions to have a specimen X-ray. You must have a specimen X-ray, and the surgeon must look at the specimen X-ray, right? This is the only country that says that you should do it, and that's why you have specimen X-rays. And we've got the CubTech or the Mozart that comes out of the UK. This is out of the US. I used to use it in the UK, that's why I've mentioned it. So this is a 3D specimen tomosynthesis, and it reduces the re-excision rate compared to standard 2D by 50%. And we've proved that, and we've published this data as well. Then there's the margin probe. What does the margin probe do? The margin probe uses radar properties to look at the tissue architecture and the tissue vascularity, and looks at things like membrane depolarization, nuclear morphology, and gives you the difference of electrical impulses between point A and point B, and the drop-off. And depending on the drop-off of that, it tells you whether the margin is positive or negative. Now, if you look at this data, brilliant, 6% absolute reduction in the re-excision rate when it comes to using margin probe. Beautiful. Problems with margin probe. no neoadjuvant systemic therapy. 30% of our patients, or even higher, if you look at certain lesions, certain triple positives. So let's say 40% of our patients will have neoadjuvant chemotherapy. No data again. Lobular cancers, small cohort. DCIS, not there. So what we've used margin probe for is re-excision figures are generalized. They're not specific. No RCTs. So margin probe is good. It's an old dog in new packaging. Margin probe has been around from 20. If you look at the first paper published by a dear friend, Mark Till from Germany, margin probe has been around from 2011. So it's not new in 2025 that we're talking about it. So what is there in the space which is upcoming? You've got OCT, or optical coherence tomography. What is that? It uses near-infrared light and provides high-resolution cross-section images of tissue architecture. So it allows for real-time assessment of excised specimen at various levels. So you can actually tell it to look at, like a book, you can open pages and look at which level of depth you want to look at. Then there's spectroscopy, there's fluorescence spectroscopy, there is microscopy and ultraviolet, lots of things, and ultraviolet photoacoustic microscopy, which is using optical and acoustic signals for imaging. So a lot. There's CT, there's MRI scan, there's micro CTs. There's a lot in the experimental space, not yet down to trials. Now, the last thing I want to leave you with is this Dutch trial. And it is interesting that this trial has 20 years of data. This is the patients within the Dutch screening population that had a focally positive margin meaning 4 millimeters or less. So they had one margin involved with 4 millimeters or less of either invasive or DCIS, right? And they looked at the recurrence rates. Now, if you look at this, the 5-year in breast tumor recurrence rate, when the margin was focally positive, the only difference was they gave it a boost. So it had whole breast radiotherapy and a boost. If the margin was negative, the boost was given on the merit of the tumor biology and the size of the tumor and everything else, so guideline driven. But if you had a small T1 tumor with a positive margin, they would boost that, right, regardless of biology. And what they found was the recurrence rate, or LR, was 2.3% when the margins were clear. And this is where you look at here. 2.9% of the margins were clear. 2.6% when the margin was focally positive, and 4.3% when the margin was diffusely positive. But they went back and they excised that. So omitting radiotherapy, omitting re-excision for focally positive margins, but boosting it so there is a higher risk of local relapse, yes, but there is no difference to overall survival. Again, it depends on which perspective you're looking at. You're looking at the surgeon's perspective. I want overall survival. Patient may want a better local regional control. So for a focally positive margin, it's worth going back to the MDT and saying, look, there's a Dutch data that shows this. Let's put it to the patient. If she agrees that she doesn't want any more surgery, doesn't want to incur more cost, then it's something that we can discuss. So the optimal negative margin is a unicorn. It's something which no longer is as relevant in today's world with good radiation that we've got, with good systemic therapies that we've got, good pathology that we've got. In certain cases, of course, in certain cases, triple negatives and stuff, it's very, very relevant. But a safe margin, we should move to a negative margin. I think the whole concept needs to change from defining what is a negative margin to what is a safely acceptable margin. Today's 2026, we should be talking about a safe margin, not about a negative margin. And safe margin, this is not coming out of any guidelines, so please don't misunderstand. This is my interpretation of what we should be doing today. And I'm fallible and I can make mistakes. So indicates the tumor burden is so low that is enough to be mitigated by both radiation and by systemic therapy. It does not imply that there's no more residual disease in the breast, because as we've shown you, there is. And a safe margin may even technically be positive, like I showed you the Dutch data. Focally positive margin, safe. Overall survival makes no difference. So all this needs to be put to the MDT. First of all, as surgeons, you need to understand the implications. Then you put it in the MDT and ask the people if they're happy to boost, not to boost. Certain things with, we're doing a lot of chest wall perforator flaps now. And if you have a focally positive margin chest wall perforator flap and you want to boost it, the radiation oncologist might tell you the flap is so big, I can't boost it. Then you have to go back to the young patient, triple negative, to say, well, I can't boost you, so you have a 4 times higher risk of a local relapse. Does she want that? And the factors to consider for re-excision, again, not guideline driven, made up by yours truly. I would favor re-excision when the tumor is broad front, multiple foci, there's extensive in situ component, younger patients, non-luminal cancers, triple negatives, luminal B, high Ki67. I would consider these for re-excision. Again, on a case-by-case basis. Focal, unifocal, negative for extensive this thing of intraductal component, 75-year-olds, luminal A's, I wouldn't bother. So what you shouldn't do when you have a positive margin is don't ignore positive margins, because as I showed you, they have a higher local regional relapse rate. Do not take larger volumes or shaves just because you want to have a negative margin or perform oncoplastic breast surgery in all the patients. Do not do more mastectomies, of course. And mastectomy may drive reconstruction and bilateral reconstructions, because you can tell the patient, let's have a mastectomy, it reduces the local relapse. You may have multifocal disease. And then because you're having a DF flap, let's do a bilateral mastectomy, because you can only use your DF flap once. So you've gone from breast conserving surgery to then making a unilateral mastectomy to become a bilateral mastectomy because you want to do a DF reconstruction. So now you've gone from doing a small operation to a massive escalation of surgery because of your fears, which are then fueling the patient's fears. So understand what we are doing and how to manage margins. So you have a positive margin, you can re-excise it, you don't have to go and do a mastectomy. So take home is, I would suggest in your unit, sit down with your oncologist friends and your pathologist and work out what is a safe margin in your unit. If it's 1 millimeters, 2 millimeters, no income tumor, so be it, but stick to that standard and then use it for everything else. Focally positive margins, close margins, use your MDT to guide decisions. Re-excision should be based on genomics in today's world, or if you don't have genomics, tumor biology. Patient has to be involved in shared decision making. Like I said, if the patient is more involved in overall survival than local relapse with a local margin, yes, luminal A patient, 75-year-old, do I want to go back and remove it? No, I'll just give it tamoxifen and radiotherapy and she'll be fine. Don't take unnecessary shaves or larger volumes, and please don't do more mastectomies. So with that, I thank you for your attention, and I think I've taken more than enough time.
Thank you very much, Mr. Kothari. That was a really extensive explanation on this topic, and I think you covered all the areas and all the dilemmas associated with this topic. We'll go into a very few questions, and I think you covered most of it. I invite anyone who has managed such patients, if you have practical questions, you can pop them as well. So I've got some questions from some of the listeners. Um, you mentioned about these neoadjuvant treatment response. So in a patient who has had neoadjuvant treatment and we've gone for a wide local excision, and there was scattered response, but the margins are clear. Would you still consider that, say, in a country where, like Sri Lanka, where we don't have MRI available at our disposal, even for patients who are undergoing neoadjuvant, would you consider that we've achieved negative margin, or is there a potential, there's a chance that we've left something behind?
So this is something which is a very interesting thing, and that's why the word is, would I recommend it? No, but I think if you look at common sense, I showed you the figure why it makes sense. If you've got scattered cells and you've got that Swiss cheese appearance, it is very likely, and that's why the American College of Surgeons and SSO and everyone has said that if you see this kind of pattern, especially in young women with triple negative breast cancers, where those patients where chemotherapies actually failed to control locally, you've shot that bow, so it's definitely worth considering it. Whether it's resource constrained or not, most of the countries that you spoke about, India, and would have frozen section and have a negative margin. And that is something that you have to discuss with the patient, because it's not only your MDT, because you have to put these things, like I said, all your eggs can't be in one basket. You have to discuss age of the patient. Am I going to give a capecitabine? Is she BRCA positive and I'm going to give olaparib? Will these have a different systemic treatment? Can she afford the olaparib? Or if it's a ERPR positive patient, luminal B, she's also got a high Ki67 with the CDK4/6 inhibitors, which are now showing things like abemaciclib are showing a 2.3% or 1% overall survival benefit at 7 years, and local regional relapse is by 27% and 31%. then definitely you can talk about it. And then your radiation oncologist, whether they want to boost. But again, if you've got a big footprint and you've got this kind of small area of disease, it's definitely worth considering it. And MRI scans, it's not that the poor countries don't have MRI scans. I strongly believe that patients who have neoadjuvant chemotherapy don't need MRI scans. So remember, when you're following up neoadjuvant chemotherapy patients, if you've done an ultrasound scan as the primary assessment of disease, that should be your go-to for every assessment. It shouldn't be like I do an MRI scan and MRI scan at the end. In India, I've seen more and more people are using PET scan to assess response. And I think that's absolute rubbish, but they're using it. So coming back to your original question, yes, definitely worth considering. But of course, it's something that there is no answer to. There can only be guidelines, because is there data to say that if you go back, you're going to find more disease? No. Does it make sense to me? Yes.
Yeah, so it's not an absolute indication, but it's patient based. Another question came about lobular cancer. We know that it's diffuse pattern of occurrence. Do you go by MRI and sort of take a wider margin when you're operating on a lobular patient?
Mm. Again, so don't quote me as a guideline, but if I have a fatty breast and you can see that tumor very well as a single unifocal tumor, I wouldn't do I don't do an MRI scan just because I want to conserve that breast. But I get the point that you can't do an MRI scan in every country. It's not available. A cheaper MRI scan today that's available is a simple contrast enhanced mammography. It's an iodine contrast. You do a CSM, and you can do a nice breast conserving surgery. The myth of doing lobular MRI scans for lobular cancers is contralateral breast cancer. If you look at the data which is published recently, only 8% of patients with lobular cancers have bilateral breast cancer. So it's not that high. And again, if it's a dense breast and the disease is like vague, the lump is vague, there's clinical pathological correlation difference, tumor feels like 5 centimeters, on the imaging is 2 centimeters, yes, I'll do an MRI scan. But if I think the tumor is 1 centimeter, the mammogram is showing me it's 1 centimeter, there's no benefit doing doing an MRI scan. So you have to make sure that you put a comprehensive assessment rather than lobular cancer on biopsy, so I'm going to do an MRI scan. It has to be all your decisions or investigations, if they don't lead to further information, are useless. So MRI scan and dense breast is a given, because you can't tell. So regardless of biology, you'll do an MRI scan. But of course, with tumor, like ultrasound says it's 5 centimeters. Mammogram shows it's 2 centimeters. There's a discordance. Clinically, it's 4 centimeters. Mammogram says it's 2 centimeters. Discordance. Yes, MRI scan. Or in today's world, even a contrast enhanced mammogram. Cheaper, faster, don't have to do it in cycle, don't have to wait for anything. Remember, an MRI scan, if it's a diagnostic MRI scan and you want the sensitivity, it has to be done in a certain period of the woman's cycle, especially in premenopausal women with dense breasts. So day 6 to day 13. So that means you're waiting for a month in triple negative breast cancers, or in a lobular cancer even. You don't want to wait.
Got it. Well, I hope that's very clear. And there's another question. A triple negative breast cancer patient was given neoadjuvant after clip. After neoadjuvant, radiologically and clinically complete response. Breast conservation was done. Histology is PET-CR, but fibrosis extends to the margin. Does this need re-excision for fear of leaving viable tumor cells, or is fibrosis at the margin is acceptable?
Fibrosis at any margin is acceptable. Fibrosis is good. If you see that you've removed an area with no fibrosis, that would be worrying, because you're not taking the representative area out. So PET-CR, you can't get dead tumor cells but don't leave a footprint. That happens with HER2 positive disease in the lymph nodes. It doesn't happen in the breast. So whenever you get cell death as a consequence of neoadjuvant chemotherapy, you will get macrophages and you will get scarring and you get everything else that happens there, which is a natural response to fat necrosis. So even when you get fat that dies, the pathologist will tell you there's something there which was there, now it's resolved. Giant cells will be there. There are lots of telltale signs. So yes, fibrosis is your friend. If you've got neoadjuvant chemotherapy, you don't need to re-excise. Please don't. But if you don't see the fibrosis, then you have to ask, and you see nice normal breast tissue with no scarring at all, Then you have to ask whether you've actually taken the representative area or the clip has migrated and you took a clip out. Yes, but they had the clip migrated.
Got it. I'm going to just use this opportunity to ask a question. In our setup, we find violation of protocol at times. People do not follow triple assessment. Who've gone
Across the world. It's not
yeah,
just across the world.
lumpectomy, etc. So in that kind of a scenario where neoadjuvant is being given after a lumpectomy or neoadjuvant given without clipping, and we plan to conserve the breast. Maybe we, at this point in time, what we use is do a quadrantectomy or do a therapeutic mammoplasty so that that entire quadrant is taken out. Um, would it be wise to say do an ultrasound scan and see whether there is a good response and go for a smaller resection, or is it safe this way?
No. If you don't have a clip to tell you where the tumor is, I would go with the original footprint or a mastectomy if it was too large. I wouldn't hazard a guess because again, you might take out an area peripheral on the periphery of the tumor, and the center of the tumor has still got cancer there. So it's you're playing Russian roulette with the patient
Yeah, true.
because you want to de-escalate surgery. I think de-escalation of surgery has to follow mandated guidelines and principles. People don't put clips, okay, I get that, but there should be something like, okay, it's the whole upper outer quadrant. And like you said, if I can do the whole upper outer quadrantectomy and I can send that for frozen section, the margins are clear, okay, I can do that. But that, like I said, take out the original footprint if you don't have something. And if you can't take out the original footprint, a mastectomy is better. But I wouldn't think it's there. Yes, of course, if the patient doesn't want to have a mastectomy, then there are things like doing multiple core biopsies. But then you said at the start of your question, resource constraint don't have all that.
Yeah.
So can I do VABs and kind of try and tailor my discussion, my excision? No, I can't. So then you have to go back to default and remove what you see.
One more question. We still stick to MRI for lobular cancers for BCS as it is one of the recommendations by RCR, 5th edition, is the question. Is it?
Yeah.
Yeah.
So again, you have to think about why you're doing it. I said to you very clearly at the start that I wouldn't do it for something which is obvious. See, guidelines are meant to give you a bandwidth in which to work. It's exactly for what you mentioned. People don't follow guidelines. So a guideline is not a rule. It's not a mandate. It's not the 10th commandment that you have to follow it. A guideline is for making sure that you've considered these things and then made a decision. It doesn't mean that, we should consider, the guideline will say, consider an MRI scan. It will not say, do an MRI scan for every lobular cancer. I don't think any guideline can be that prescriptive. So remember, a guideline is something that tells you, it's like, it gives you a basic bandwidth in which to work.
Thank you very much. Last one or two questions. Because of oncoplastic breast surgery, as we discussed, there's a lot of tissue rearrangement. Coming with therapeutic myoplasties or even ICAPs or any perforator flaps. So if you have frankly positive margins, and if there is a little bit of delay, let's say in our setup, histology sometimes take a bit of time. How can we confirm the patient, or is there a confirmation that there is no spillage of tumor during operation, or there is no spread in the cavity which is larger now than the initial malignant cavity that we resected?
So I'm sorry, I don't understand spillage of tumor meaning.
So initially, if you did a wide local excision, the cavity would be small, but when you do tissue rearrangement, the cavity becomes larger. So is there?
The cavity should become smaller, not bigger. Why would you do tissue
But
rearrangement?
if you raise a flap, or if you just
So I
resection.
understand therapeutic mammoplasties, this can happen.
Yeah.
So with a delay, so one thing you must do whenever you do a nice oncoplastic resection is you should have a schematic. You should have a roadmap of what you've done. It should be drawn. It shouldn't be described. You should show that I did this tissue went here, this tissue went there. And remember I said during my talk that re-excision should only ever be done by the same surgeon. It doesn't matter if it takes a couple of weeks more, because the goalpost doesn't change. The lateral margin is going to remain the lateral margin. and the medial margin is going to remain the medial margin. You've put clips there, so a good radiologist will also be able to find the margin for you with an ultrasound scan and say, these are the clips here, these are the clips here, these are the clips here, especially when you've got a perforator flap. The problem will become if you've got a level 1 closure and you've closed everything, and then you can't find the margin, then it's a level 1 closure, just remove the whole cavity and send it.
Got it.
Delay in that doesn't matter. You should do a re-excision where it's indicated.
I think you might have answered this already. Can I know a wide local excision or a mastectomy specimen? What is the minimal margin clearance value that you should consider for re-excision of positive margin?
So I already said it depends on your local MDT. Americans say no inguinal tumor or no tumor in ink. British guys say 1 millimeter. I say 1 millimeter for invasive and 2 millimeters for DCIS.
I think we had a really good discussion. I think you've answered all the questions, and your presentation covered all the areas and the dilemmas. I should thank Mr. Kothari for your time. I know you have some personal commitment as well, and you made time for us. Thank you so much.
Thank you for having me, and I hope it was worth your while.
Absolutely. Thank you very much. And I invite everyone to send us an email if you have any further queries, and we'll see you again with one of the webinars. Thank you again, Mr. Kothari.